Good morning, my name's Josh Miller. I'm a community paramedic for West Midlands Ambulance Service. I started 3 years ago, and before that I was a student for 2 years at Worcester University. What surprised me when I started as a student was just how sometimes we weren't very good at resuscitation. So if you think of a out-of-hospital cardiac arrest, resuscitation, that to my mind was something that we should be good at. It's a very serious situation where patients stopped breathing, their heart stopped, but sometimes it seemed to me that the team wasn't quite all there, wasn't quite working as one unit. The more I spoke to people, the more it seemed there was a kind of dichotomy of views between a small but vocal minority who said, resuscitation, that's really easy, you don't need to think about it, it's protocol based, it's laid out as a script for you, and you don't need to get much beyond following those steps. And then the vast majority of people said, well, resuscitations, they're always chaotic, they never go quite right. And I started wondering, well, why are they always chaotic? Why do they never go quite right? There didn't seem to be anything beyond that point of saying they're chaotic. It seemed to be it stopped dead at, well, they never go quite right, it's always chaotic. End of. No further thought beyond that point. And I got quite interested in that. And just last year, I decided to do a programme which was provided by the NHS Leadership Academy, the Mary Seacole programme. And as part of that, I did a lot of work into how we can improve resuscitation care out of hospital. One little part of that was what I'm going to talk to you about today, which is measuring for improvement, views from the front line. So views from staff of how we can improve. What I'd like to take you through today is, first of all, why would we want to get views from the front line? We've already got overviews, lots of percentages and statistics about performance. We know roughly how well we're doing with our care. Why you'd want to get views from the very front line, so where the care is being delivered. Then a brief look at whose views we're deciding to gain, and a little touch on stakeholder analysis there. Thirdly, looking at a couple of techniques that will be quite accessible for you to use to find views from the front line. And then finally, looking at dissemination, so taking it through to events like today and getting your work out there, which I know some of you have done from posters that I've seen around, and the fact that some of yourselves are presenting to us later. So I'll start us off with why would you want a worm's eye view? And I'm going to start off with the opposite. So this is a bird's eye view. This is a description from a case that I went to recently. So it's not a research-based scenario. I've given you an operational scenario because I'm not a research paramedic. I work operationally on the road, and I've done this as part of something that I've done alongside my day job. So those of you who are unemployment or students, there's no reason you can't do research or service evaluation while you're still working. What I was sent to was coded as a RED 2, which is our high priority, RTC, which is a lovely TLA, which means three-letter acronym, road traffic collision. We used to call them road traffic accidents, but it was decided that they can't be accidental. Someone's always at fault. We shouldn't imply that they've just happened, that something has happened because someone's done something that they ought not to. So road traffic collision, and then entrapment, ejection, rollover. That's not all of those things all at once, although that would be an unfortunate day. But any of those gets the attention of our eyes in the sky, of our control staff. And the case that was described to me was a heavy goods vehicle that's overturned on the M5 with 2 patients at scene and coal leaking from the vehicle. That was the description, coal leaking. And I think I see some puzzled faces and I think, how does coal leak? Well, we'll come to that in a minute. I was told that air desk were aware, helicopters were on standby ready to come to this incident. And our hazardous area response team are paramedics who are trained to go into the hot zone with protective gear and protective equipment. Were on standby. Police and the fire service were en route. So you're imagining quite an unpleasant scene at this point. That's the bird's eye view to start off with. I'm going to give you the worm's eye view. So this is what we found. I think you can see, for starters, the location wasn't quite as described. So this isn't the M5. This is the M5 junction 1. Some of you recognise it, halfway around the roundabout, coming towards the Albion ground. The next thing that was not quite as described was 2 patients at scene. Well, one has clambered out, so he's no longer entrapped in his cab. That's it. The lorry driver stood by the road rather sheepishly explaining to police and attendants what's happened. Someone swerved and I swerved and then everything fell over. The other patient that was there was someone who was quite upset by it, but she fortunately wasn't underneath this lorry, but she witnessed it. She was quite upset, so she was shaken, not stirred, and certainly not squished. So that's the next point that was gleaned from having a worm's eye view there. Finally, if you have a look at this coal that's leaking out, it's difficult to say without being there that the people probably should have recognised this substance as not being coal. Visually, you're blessed because you've just got the slide of this here, but that, what was described as coal and possibly dangerous, was actually an inert substance, and that's why I handed over to my control. That was a lorry load full of manure. So I think you can see that sometimes the view from the front line is more useful, or certainly adds something to the view from above. So we're very good at providing colour charts. You've probably seen your traffic light signals of compliance with measures in hospital or in the community, reds and greens. But sometimes it's nice to have a little bit of added texture, and that's what I'm talking about today. When you're trying to get this texture, it's important to think about who you're going to speak to and who you're going to gain these views from. Now, this is something that's been brought up by a number of people. This is a stakeholder analysis, and there's lots of different terms they use. Sometimes you'll see different versions of these descriptive names. Sometimes power will be replaced by influence. But essentially, what you're looking at is thinking about who you might talk to about something that's happening, and then trying to place them in one of these settings, and then deciding where to focus your attentions. Now, immediately you're thinking, if someone's got power and interest, they're players, might be someone like a senior strategy maker, or hopefully yourself, because I'd hope none of you would do any research that you weren't both interested in. And by default, if you start doing research in something, you gain power, because you're then putting out your views on something in a way that other people will be reading. If you move down and look at someone who has a lot of power but very little interest, that tends to be something like administrators in an organisation have a lot of power to make things happen or to slow them down, but they might not have a lot of interest in that topic. And finally, researcher skill. So myself, I'd done no research training before I did this, and I needed to find something that I'd be comfortable with. So looking at something that would be a good way of getting views from the front line effectively but inexpensively. Does anyone recognise that? That wasn't very loud. That was a very loud from here. Does anyone recognise that? Yes. Lovely. Okay. I consciously haven't put the title of an article up because I know that you will probably want to write it down very carefully. What I would very much recommend you read is something by authors Glasby and Beresford. Some of you will be familiar with this already. So it's a 2006 piece, Who Knows Best, and it's about the move from evidence-based practice to knowledge-based practice. So Glasby is Glasby, Beresford. I'm looking around seeing some people nodding, saying, yep, read that. It's quite a short piece. It talks about re-evaluating this hierarchy. So this hierarchy of evidence moves down from at the top, syntheses of lots of randomised controlled trials and seeing what the very highest level of evidence for a question is. Moving down talks about randomised controlled trials where you try to remove variables from the mix. Then looking at cohort studies and case reports, and finally puts expert opinion at the bottom at a very lowly pedestal. Now what Glasby and Beresford talk about is that that's okay for some questions. So you want to find out whether a drug works or doesn't work, then yeah, you want to use a randomised controlled trial. So at the minute in my trust, we've got Paramedic 2 trial, which is comparing water with adrenaline in cardiac arrest. So it's comparing a placebo with the current standard treatments. We don't know whether adrenaline works in cardiac arrest. So we're using a randomised controlled trial to do that. I'm involved in that trial purely as a paramedic, so I might be giving adrenaline or water to my patients, not beyond any of that. But that's a very good way of answering that question. What Glasby and Beresford make clear is that it's not a very good way of answering other questions. So you want to know, why aren't our teams performing at a resuscitation in a synchronised way? You're probably not going to be able to do a randomised controlled trial on that. There's lots of issues with that. There's cost, there's controlling the variables, and it doesn't give you a good level of texture either. So they talk about getting views from the front line and trying to move this expert opinion up for answering some kinds of questions. One of the ways that they talk about that is storytelling. So if you think of trying to gain views from your frontline, it's about having an ear for the stories that people are telling you. So before I started doing the research that I did, I heard one story in particular which caught my ear, and I pinned it away, and it featured in one of the assignments that I did, because this was an academic course that I did last year. And that was a case of one of my friends went to a resuscitation attempt, tried to coach someone on the scene during the case in their chest compression technique. I think all of you are trained BLS at the very least, perhaps, so I'm getting some nods. So it's very important if someone's heart stopped that you press on their chest for them to compress their heart to keep them alive while you're trying to get them back into a better state, as it were. She tried to coach this person. It was a very experienced member of staff that she was speaking to, and she, like myself, was relatively novice in the job. She said, "Oh, I think you press a little harder, a little more in the centre of the chest." And the member of staff that she spoke to stopped, looked at her, folded her arms and says, "I know how to do resuscitation," in the middle of this resuscitation. That story tells us a lot more about some of the interpersonal issues that are happening at scenes than any number of analyses of how many patients have been resuscitated successfully, how many haven't, because that doesn't tell you why that's happening. And that's how looking at things from a different point of view, gaining views from the front line, can help you. Another thing that I considered was, okay, I've got some views from people I know, but I'm quite limited in how many people I can talk to. I wanted to get a broader view. So still from the front line, from staff, but I want to get a few more views from across the workforce. And a very inexpensive and quite straightforward way of doing this, albeit that it's not as easy as it looks, and I know a few people who are speaking today will be much better at questionnaire development than me, is to use a questionnaire or a survey. And that's something I did, and I used an internet-based survey to gain the views from the workforce within my trust. That was advertised in our weekly briefing and our newsletter, and then put out there. And I'm going to take just a few minutes to explain how the results came back from that, and also give you a few tips. My first tip is, when you're developing a questionnaire, take some advice on it. Probably don't have as many categories as this. When you see lots of little categories with 1 and 2 and 3 people on it like that, probably could have chosen my categories better, probably could have amalgamated them. This describes the role or training level. So if you're talking about how people are thinking about patient safety issues, when you're then going up to boardroom meetings, things like that, they're going to want to know, well, who was it who was answering these questions? So you can see here, in the main, these were paramedics that were answering the survey for me. Again, they're going to want to know, well, was this a bias because of being novice, or were these people experienced? And again, broadly, if you look at the green here, this means they've had 6 or more resuscitation attempts they've been part in. So at that point, we're starting to say, well, they're no longer novice at that point in this skill. If they're saying there's difficulty still at this point, it isn't something because they're fresh on day one, it's because there's something more going on. And again, if you're advertising internet-based surveys, especially if you leave them, as I did, anonymously, because if people are anonymous, and anonymous to you as well, not just confidential where you would know their name but not tell anyone else, but this was anonymous to me as well, quite important you make sure that you know where they're coming from. Views from other trusts are valid and interesting and useful, but I wanted to make sure that the bulk of the staff that were replying were from the trusts that I worked for. And you can see here there were a few that worked from other places. The reason for that being that our newsletter goes out to people that work for other trusts as well that have some kind of stakeholder arrangement with us. So, for example, one of the others there is a police officer who works in the city centre of Birmingham, but receives the newsletter because he does a lot of partnership working with us. And the reason I know that is not because it wasn't anonymous, but because he put it in free text later on in the survey. So it's important to do that. Then I've used here some kind of a Likert style scale. So I would strongly recommend using at least 5, possibly more scale points. Other experts, if you read methodological texts, will talk about using 7 points. some people will argue for forcing an opinion one way or the other, so strongly agree, somewhat agree, don't have a middle point, and then say somewhat disagree, strongly disagree, so you get lots of views either way. If you're going to do that, keep it consistent. So I've kept it consistent between the questions here. This week I filled out a survey for someone where there were 5 responses on one set of questions, 4 responses on another set of questions, and then a set of questions where the statements were listed and the options were yes and no, which is fine, but it makes you think, well, I'm not really as strong as yes, and I'm not really as weak as no. I'm somewhere in the middle, but you're forced to choose an option, which for some people will be a little bit confusing for them. What you can see broadly here is that people were relatively more confident in their practical skill and relatively less confident in their abilities to communicate with the patient's family, but still on the whole, fairly happy. The green is broadly all the way across the bar there. We've got a few % of people that were not quite happy with their own abilities. This slide and this set of questions was all about that person themselves. Then I asked a set of questions which is about how they work as a team. And we had a bit of a change there, a bit of a shift towards people being less confident. So this phrase here is lifted from another article, which I did quote in the survey. And it's talking about a highly synchronized and disciplined pit crew. I had a couple of objections in free text to that use of that statement. They said, well, my patients aren't Formula One cars, which, you know, take on board. So you've got to think very carefully about terminology. But broadly, people thought, yeah, we should be highly synchronized, we should be disciplined. Whatever the outcome of the resuscitation, it shouldn't look to yourselves or to other people to be a chaotic mess, as we were saying it seemed to be. As we move down, people say, oh, they have in the past had some that were less than highly synchronized, less than disciplined. As we move to the next one, we ask, if you were part of a resuscitation team next week, would you be sure it was highly synchronized and disciplined? And you can see even fewer people are confident of that. And that, I think, has shown that there was an issue within my trust. I gave a lot of free text boxes and gave a lot of options to explain why people thought this might be the case. I'm not going to talk about that today, because I'm quite pushed for time, but I will talk to you in a minute about where you can find the answers to what kinds of issues have seemed to be the reason for this. And I will talk to you about that in a moment or two. And that's in the dissemination part. Part of the dissemination from my point of view now is that I've done this course, this Mary Seacole program last year, no cost to myself and no cost to my trust, so I've tried to put it out there and get around as much as I can explaining what I've found. I put an article in my trust's weekly newsletter, and I've had replies from that, and people come up to me and speak to me and say they've read that. I've gone to some meetings within my trust, so clinical steering group, and I've gone to conferences as well, so a quality improvement and innovation research conference earlier this year in Nottingham, and presented a poster presentation on the results of this research. So that's a little bit about dissemination, but as I said earlier, we want to look at things that are inexpensive. Paying for me to go up to Nottingham and have someone escort me as well. My manager kindly agreed to go. Again, starts to eat up into being a fairly expensive thing to do. So how can we get your ideas and your results and findings out there less expensively? We can do things like this. So this is plasma screens. Now, plasma screen I would say is a fairly expensive thing, but these were already in situ in our ambulance stations, but they were showing at the time performance charts. So how have we responded to 999 calls that day? How have we responded that month? Greens and reds and flows of how everything's going. But I felt that it probably wasn't of great interest to staff, because if you're given a 999 call, you're not going to go, well, I'll really put my foot down today, or I'll ease off because our performance is good or our performance is not so good. You know, you're going to drive appropriately. Whether you reach the time limit target or not is probably not something that you're thinking about. What I did instead was try and put through some of the findings from both literature review that I did of the things that impact on successful resuscitation, and also some points from the research as well. So here we're talking about ventilating too quickly. This is from a trial, actually, an experimental trial, and talks about defibrillation of pigs. So these pigs were anaesthetised, so they didn't suffer, and then they were put into ventricular fibrillation deliberately, and then left for a period of time with resuscitation being delivered by machines, and then defibrillated. And it talks about how many were successfully defibrillated after they were ventilated slowly, and then only one poor pig, or one lucky pig and 6 poor pigs, was successfully defibrillated when they were ventilated quickly. So I've put some of those slides on, and those were rolling through, and they were out in the ambulance stations. And the feedback that I got from staff was they liked having things that were clinical and operational and relevant to them rather than the performance figures. So that's one thing you can think about, and a lot of hospital sites certainly have got screensavers that are already putting out things about policies, putting out things about topics that are of relevance to staff. I did promise you I'd tell you how you could find out about the broader free text answers from the resuscitation. If you go back into the room when we have coffee later on, you'll be able to see one of the posters is my one, which went up to Nottingham earlier this year. And some of the free text answers are in these green bubbles here, so you'll be able to have a look at that. From a dissemination point of view as well, when we're talking about cost, just to give you an idea, that was an I believe A0 poster, and it was £35 to be printed, and then £10 to have that laminated as well. So we're talking £45, so it's sort of a much more affordable scale if your frontline practitioner is struggling to get hold of funds to do research and to disseminate the research. If you're doing research or service evaluation and you don't get it out there, that's the final step missing. So I think you need to get what you find out there into the wider world as well. So hopefully that's given you a few ideas of why we think that we should get views from the front line, who those views could come from, a few methods to do it, and then what to do afterwards. So thank you very much.